I remember hearing about Expiril from the colorectal surgeons doing combo cases and, the hemorrhoidectomies. They were telling me that the patients would come in 72 hours, like, on the dot when the Expiril would wear off because they were experiencing no pain, and then all of a sudden they were having routine post-op pain, and they thought something was wrong, like the sutures had broken down or something like that, and they are very facile with doing the fascia. That's the technique, right? Is injecting it along the fascia, or do you do it along the skin and the subcutaneous tissues?
Well, you really want to block the ilioinguinal and femoral and iliogenital nerves that run down the rectus abdominis, right? So if you're doing a C-section or an open case and you're doing soft tissue infiltration, there's a couple of unique things about Expiril because it's encapsulated by a liposomal multivesicular envelope, right? So the pivocaine is encapsulated. And depending on where you inject it, the blood supply to that site, it'll break down that liposomal covering, and then the bupivacaine, infiltrates into the tissue. So you really, if you're doing soft tissue infiltration, you really want to do a good bathing of the fascia, below the fascia, above the fascia. So you want to inject below and above the fascia to bathe the fascia completely. Every centimeter you do an injection. It's not like Marcaine. Marcaine, we put in the needle, aspirate, and infiltrate, and it flows into the field. This is a different molecular weight, and there's millions and millions of these encapsulated particles you're injecting. So it has a tendency to kind of stay where you put it. So you want to be overzealous and really do a lot of infiltration below the fascia, above the fascia to hit those nerves. But the good thing is, how often do you all do an operation that a patient 72 hours out has moderate to severe pain? That's kind of unusual, right?
No, not very often, and I tell my patients, I say, "This lasts up to 72 hours, sometimes longer." I've had patients 72 to 96 hours with the Exparel, and I'll tell them your peak pain is around 48 hours, especially with the C-section and with my robotic hysterectomies. And I said, "So if we can get you that far out without narcotics, controlling your pain, you're probably good. Maybe just a little Motrin if you need it, be a little sore at that point, but you're right, you're not gonna have any more severe pain." And I do the same thing you do with when I do my C-sections, I will, because like Dr. McCarus said, it stays where you put it. So do in a fan-like fashion at the corners, above and below the fascia, and then I'll go along above and below the fascia across the incision, and then into the muscle and into the sub-Q a little bit with my extra what's left over.
So, we talked about it for open surgeries. It sounds like, the TAHs, the C-section, the fan and steels. Do you guys use it for slings or for laparoscopic surgery, robotic surgery for the incisions? Is there, like, any utility in that?
Yeah, absolutely. Yeah, so I use it on all my, robotic hysterectomies and robotic surgeries. I'll infiltrate into the port sites around the fascia, and then we will, place it along, like just like we said, we put it where we want it. We try to inject and get those nerves that are gonna cause the pain. And then some of my GYN oncologists that are at my hospital now are injecting into the, vaginal cuff. And I don't know if Dr. McCarus, do you do that?
And the way I think about it, any soft tissue infiltration, there's an application. So I really like it for the vaginal cuff because if you think about, tissue injury and the healing of tissue, that's what it's visceral pain and somatic pain, right? So if I do an open, here's what I have found. I kind of do there's no data on this, and I don't know if it's reasonable. I think it is, but Expiril will volume expand to 300 mLs. You don't dilute the ability of the liposomal bupivacaine to dilute. It doesn't dilute it. You get the effect. So anesthesia will do a tab block, and they use 30 cc's on each side, and they'll bring in an ultrasound machine, and they'll scan the transverse muscle and the fat and the peritoneum, and they'll do a guided infiltration, right? They'll use 30 cc's on the right side and 30 cc's on the left side. Well, that's 60 cc's. So if I do an open multiple myomectomy, which I do, I still have 240 cc's of Expiril that I can infiltrate. So I'll let them do the tab block. I'll do soft tissue infiltration of the abdominal wall. And then what I do that I have found, I think it helps. There's no data on this. This is just anecdotal. I'll actually inject the uterus with Expiril where I've cut into the uterus and caused tissue injury and tissue trauma on a myomectomy. And I'll do organ infiltration for visceral pain, myomectomy, posterior repair, anterior repair. Back to my Bartholins. I know we hate Bartholins, but I'm telling you, my aha moment with Expiril was a young girl that I did a left excision of a Bartholin's gland, which we all hate. We know it's painful, it's bloody, it's a terrible operation. And I infiltrated the whole surgical field with Expiril, and no kidding, zero post-op pain. One of our urogynes here at this hospital had bilateral mastectomy and infiltrated Expiril. I know her well. I've known her for 25 years. She said, Steve, I had zero post-op pain. So any soft tissue surgery, you can apply Expiril to that location. And the thing is, I mean, it can't hurt and it only can help. Your chronic pelvic pain patients, 18% of endometriosis patients are treated with opioids to handle their pain. And now you got to operate on that patient. So you really have to set the stage with patient shared decision making, if you will, that I'm not going to give you 30 Percocets. We're going to use a medication to reduce post-surgical pain. Remember, the studies really show that there was, I think, what was it, Paula, maybe you remember, I think it was 40 or 45% reduction of opioid consumption, reduction of pain with Expiril. I mean, the data is there. So I think if you talk to your patient about what you're doing prior to the surgery, the whole goal we see in the C-section data, an Expiril tap block C-section patient, the Foley's out, the IV's hep locked. She's not getting IV Demerol or morphine or what have you. She's up. And you can breastfeed. The plasma concentration of Expiril in breast milk is less than, what is it, Paula, 1%?
It's less than 1%. So it's safe in breastfeeding. So my patients love that as well. And, my hysterectomies go home the same day, which I'm sure yours do too. And it's really nice because they don't have any pain and they don't need to take their narcotics.